Hi, this is Thaddeus Pope, and this is a practice presentation for a talk at the National Clinicians Conference on Medical Aid in Dying on February 14th, 2020. So the title of my presentation is Medical Aid in Dying, 6 Variations Among U.S. State Laws. So what I'm going to talk about is the law, even though this is a clinicians conference. And that's because even though the law is only one barrier to access to medical aid in dying, it's a really big one. So we heard that there are 10 jurisdictions that permit MAID. Most of them, all of them, follow the Oregon model from 1994. But they don't follow that model exactly. There are some variations from state to state. And so what I want to talk about are 6 of those variations from the Oregon model. So variation number 1, is the third capacity assessment contingent or is it mandatory? So we know that there are 2 capacity assessments required in every state, but sometimes 3. Sometimes a third is required. Now, that third one doesn't need to be a physician. It could be a clinical social worker. It could be a psychologist. And we also know that it rarely happens. But in Hawaii, things are a little different. In Hawaii, it's always 3 capacity assessments by 3 different clinicians. Right? In Hawaii, the statute says the attending provider shall refer the patient for counseling. Right? This is not contingent, as in other states, not contingent upon doubts or concerns about the patient's capacity. Right? Every patient in Hawaii always gets a third screening. So that's variation number 1. Variation number 2. What is the duration of the oral request wait time? Is it 0, 15, or 20 days? So most laws require the patient to make 2 oral requests separated by 15 or more days. But in Hawaii, again, things are a little different. In Hawaii, the wait time is 20 days. And many argue that this constitutes an undue burden. So most patients can't wait that long. I mean, most patients can't even wait the 15 days. Right? During the process, many patients either lose capacity. In fact, a majority of patients either lose capacity or die in the waiting period. So this year, Oregon, which only had a 15-day waiting period, amended its statute. It became effective at the beginning of last month, and it says that the clinician can waive the waiting period if death is likely to occur before the expiration of the period. And now Hawaii there's a bill recommended by the Department of Health, which would also waive the period in a similar way. So is the waiting period between the 2 oral requests, is it as little as 0 days as it might be in Oregon, 15 days as it is in most states, or 20 days as it currently still is in Hawaii? So that's variation number 2. Variation number 3, is there a written request wait period? So some states don't have a written request wait period, like California and Colorado. Many do have a 48-hour wait period, which says no less than 48 hours shall elapse between the written request and the prescription. And that's the law in 6 states. Now, that's not really consequential normally because the 15-day waiting period for the oral request and the 48 hours for the written request could run concurrently, so it's not an extra 48 hours. But in Vermont, it is. In Vermont, the 48 hours runs consecutive to the oral request wait period because the law says that the prescription can't be written fewer than 48 hours after the last 2 occur, whether that was the written request or the second oral request. So in Vermont, it's always 17 days, 15 plus 2. So that's variation number 3. Variation number 4, must the patient ingest the drug or must the patient take the drug? So this variation concerns the route of drug administration. So every state requires that the patient take the final overt act. But the laws use different verbs. Some say ingest, some say administer, some say take. 4 states use the word ingest, these 4 states. And that implies a gastrointestinal route. So patients could take the medication by mouth, they could press a plunger on a feeding tube, they could press a plunger on a rectal tube. But some patients can't swallow, where they have poor absorption, or an obstruction, or uncontrolled vomiting. And we know in the DOH official data, for example, in Oregon, that there's a significant complication rate of patients who had difficulty ingesting or regurgitation. So Oregon last year tried to change the verb in the statute from ingest to take. And this is basically what you have in most of the remaining states. These states, they already have that verb. And they already use the word take instead of ingest, or self-administer instead of ingest. And I hope it's intuitive that the word take is broader than the word ingest. And specifically what it would include is IV administration. Now, some might say, well, the End of Life Options Act also say that they don't authorize lethal injection. That's not really an obstacle, though, because this is not, first of all, it's not the physician ending the patient's life by lethal injection. It would still be self-administered. The patient would still take the final overt act. So that's variation number 4. Variation number 5, what duties are there when the clinician opts out? So we know that participation in medical aid and dying is voluntary. You can assert a conscience-based objection. You don't have any duty to participate, to inform, or to refer the patient. But you do have to send the patient records. So if you object and the patient finds a new physician who is willing to participate, you have to send your records to the new physician, even if you feel that makes you complicit in an immoral act of MAID. Now in Vermont, things are a little different. You have to do a little bit more. There, because of this lawsuit, you have to either inform the patient about her MAID option or refer the patient to a place from where she can learn about this option. That's variation number 5. Variation number 6, what duties are there when the facility opts out? So we know this is California data, JAMA, right, that almost no religiously affiliated hospitals participate in MAID. That's okay, they can do that. But what about individual physicians who work for or in those systems? The traditional rule has been that when the physician is off premises or outside the purview of the institution, then she may still participate. But that's in fact the law, the End of Life Options Act in Colorado. But this Catholic system has internal policies and procedures that say you can't participate even when you are acting outside the purview of your job at Centura. So this physician, Barbara Morris, wanted to help this patient with MAID, but Centura said you can't do that even when you're acting outside the purview. And even though the Colorado End of Life Options Act says you can, that's unconstitutional because we as an entity have First Amendment religious liberty rights. That case is still in progress in the Colorado courts. So that's 6 variations on MAID laws in the United States. Thank you.